Today will be two sessions. The first session will be held by Dr. Mohammed Al-Kilani, and the second session will be held by Professor Gonzalo. Dr. Mohammed Al-Kilani is a consultant neurologist and epileptologist and in charge of neurophysiology in Rashid Hospital. He had his residency and fellowship program in the United States of America. He has many contribution done in ward of epilepsy and epilepsy service in Rashid Hospital. And we are in process of having EMU program in Rashid Hospital. Dr. Kilani today will be holding a lecture on new classification of epilepsy. Dr. Kilani, the phone is yours.
Okay. Well, thank you, Dr. Abu Bakr, for introducing me, and it's my pleasure to share with my colleagues my talk today about the new classification of seizures and epilepsies. Actually, the classification, just for a quick overview and historical overview, classification of seizures, epilepsy, and epilepsy syndromes creates a framework for clinicians, researchers, and patients and their families. The classification has evolved over the years, and in 2017, the International League Against Epilepsy published an operational classification of seizures and epilepsies. Understanding this classification is important in the diagnosis, treatment, and understanding of seizures and epilepsies, including epilepsy incidents. I hope this is my first time using this Mac. Okay, so seizures and epilepsy types were not distinctly classified until 1969, where the first classification was done by Gastou. And actually, there was some initial resistance for this until 1970. Then in 1981, the International League, informed by advances in technology, especially with the introduction of video EEG, published a classification of seizures, followed by a proposal of epilepsy classification in 1985, then was revised again in 1989, wherein the concept of an epilepsy syndrome was introduced. Oops, I'm going back. Okay. This here, actually, I'm just showing, probably the article for people who are interested to go and read in more details. This paper was published by Robert Fisher et al., and they are actually the task force assigned by the International League Against Epilepsy to come with the new classifications. So now there are practically clinical definitions of epilepsy in 2014 were formulated. Epilepsy initially was considered as a disease of the brain, defined by any of the following conditions. Actually, at the beginning, we used to say at least 2 unprovoked or reflex seizures occurring in more than 24 hours apart. However, then they came up with 1 unprovoked or reflex seizure, and the probability of further seizures similar to the general recurrence rest after 2 unprovoked seizures occurring over the next 10 years. And what does that mean? For example, we know that, for just an example, a patient probably who had a stroke, then developed a seizure maybe a couple of months later, then we know probably he has the similar seizure recurrence, at least 60%, as somebody who has 2 seizures within a period of time more than 24 hours. And also, there was the diagnosis of an epilepsy syndrome, where it became more important to come up with the diagnosis of a syndrome. Now, epilepsy is considered to be resolved for individuals who had an age-dependent epilepsy syndrome, but are now past the applicable age, or those who have remained seizure-free for the last 10 years with no seizure medicines for the last 5 years. Again, here, epilepsy is a disease of the brain defined, actually, I think I'm going back and forth. Sorry. Oh, yes. Okay. Then going back, so we can understand what are the differences between the new classifications and the old classifications. The international classification of seizures, we'll talk about seizures first, then we talk about epilepsy. In 1981, it was dichotomized into partial and generalized seizures. And as you see, partial also was divided into simple partial, complex partial, partial evolving to generalized tonic-clonic seizures, depending on the level of awareness. And generalized seizures were classified into 6 different types, as you see in this slide. And the third class was called unclassified epileptic seizures. But that may create a lot of confusion. And as you see the terminology here, simple partial seizures, simple, probably the term of simple, it may be misleading among different clinicians or even for the patient himself. They may understand it's simple, that doesn't have significance. Complex partial seizures also may impact some other meanings for patients or even for clinicians. Complex, which makes it more dangerous. So as you see here, the main difference was the impairment of consciousness. It may begin with simple symptomatology, then evolve into complex partial. As you see, I don't want to go over details for the sake of time. I think most of us are familiar with these classifications. This slide shows that the simple partial seizures also can be classified according to the focal symptoms or signs. As you see, it could be associated with motor signs, or it could be consisting of somatosensory or special sensory symptoms. And sometimes it could be just autonomic symptoms, as epigastric sensation, pallor, sweating, flushing. And actually, these were missed a lot of times by some clinicians other than neurologists. And there are patients who may present with psychic symptoms as simple partial seizures in the past. So then the revision of this classification was done by Fisher et al. In 2017. The motivation for revising the old classification are some seizure types, for example, tonic seizures or epileptic spasms, can have either a focal or generalized onset. And the lack of knowledge about the onset makes a seizure unclassifiable and difficult to discuss with the previous system. Retrospective seizure descriptions often do not specify a level of consciousness and altered consciousness, although central to many seizures is a complicated concept. Some terms in current use do not have high levels of community acceptance or public understanding, as we mentioned before, such as psychic, partial, simple partial, complex partial. And some important seizure types were not included in the previous classifications. So, to come now, this is a revised classification for seizures, and this is a simple one. It can be, and there is an expanded slide. It will show the same classification, but more expanded. Actually, this can be beneficial for clinicians who are probably not neurologists or people not specialized in epilepsy, so it could be easier. As you see in this slide, with the new classification, they classified seizures into focal onset and generalized onset, and it could be unknown onset sometimes, whether by history, especially in areas where some clinicians probably don't have access for diagnostic studies. And as you see, I don't have the mouse here. I don't know for some reason. The focal onset also can be classified focal onset aware or focal onset impaired awareness. And adding to that, the motor onset, they could be associated with motor onset or non-motor onset. And they may evolve to what we see here, focal to bilateral tonic-clonic seizures. Generalized onset also, they could be motor or they have non-motor manifestations, as we see in absence seizures, for example. Then there is unknown onset, sometimes by history, especially if the EEG is normal, imaging studies are normal. The history may not be clear, and it could be, it may have motor, tonic-clonic, or other motor manifestations, and we may not know by history if it's generalized or focal onset. This is the expanded version. As you see, focal onset aware, or could be focal onset impaired awareness. And by the way, here we go hierarchical, we go vertical in classifying these seizures, but doesn't need to be hierarchical. So we don't, sometimes the physician, it could be difficult for him to get all of these details. So we may end up saying focal onset aware or focal onset impaired awareness with motor manifestations. And it can evolve, as we said, to focal to bilateral tonic-clonic. Again, the generalized onset, they could be having motor, generalized onset, tonic-clonic, or it could be clonic. As we see, this slide is more detailed, and this still also can be simplified, but also can be more expanded, especially for epileptologists and people who are working in epilepsy programs, especially if they do epilepsy surgery, where they may need to go through more details. So main changes in seizure type classification with the new classification, they changed the term partial to focal. Certain seizure types can be either of focal, generalized, or of unknown onset. Seizures of unknown onset may have features that can still be classified. Awareness is used as a classifier of focal seizures. The term dyscognitive, simple partial, complex partial, psychic, and secondarily generalized were eliminated. New focal seizure types include automatism, autonomic, behavioral arrest, cognitive, emotional, hyperkinetic sensory, and focal to bilateral tonic-clonic seizures. Atonic-clonic, epileptic spasms, myoclonic, can be either focal or generalized, as we will see in the next coming slides. New generalized seizure types include absence with eyelid myoclonia, myoclonic absence, myoclonic tonic-clonic, myoclonic atonic, and epileptic spasms. So now we'll talk about focal versus generalized. Focal is defined as originating within a network limited to one hemisphere. While in the past, when people, they used to say partial, it's a vague term, and some people, they may think it could be originating only in one spot, let us say in one hemisphere. As you see here, it's a network limited to one hemisphere. Anyway, they could be discretely localized or more widely distributed. Generalized from onset seizures were defined as originating at some point within and rapidly engaging bilaterally distributed networks. The International League Against Epilepsy Task Force emphasized the concept of bilateral rather than generalized involvement of some seizures since seizures can be bilateral without involving a brain network. The bilateral manifestations need not to be symmetric. The term focal to bilateral tonic-clonic was substituted for secondarily generalized. The term generalized was maintained for seizures of generalized onset from the beginning, and that, for example, you see some seizures, they are bilateral, supported by an EEG that showed generalized epileptiform discharges that are usually symmetrical in both hemispheres, as the condition with absence seizures. Now, seizures of unknown onset, they can be motor or non-motor. The most important use of this classification is for tonic-clonic seizures for which the beginning was obscured. Further information might allow reclassification as a focal or generalized onset seizure. So by the way, I would like to mention here, when you see a patient in the clinic, you may be able to describe, to say focal awareness, focal non-awareness, and you may stop there, or you may say generalized, but with the follow-up visits and having diagnostic tools utilized, then probably we may change the diagnosis, or we may come with a more clear diagnosis. Epileptic spasms and behavioral arrest are other possible seizure types of unknown onset. They could be whether focal or could be generalized. Epileptic spasms may require detailed video EEG monitoring to clarify the nature of onset, but doing so is important because a focal onset may correspond to a treatable focal pathology. An unknown onset behavior arrest seizure could represent a focal impaired awareness behavior arrest seizure or an absence seizure. So it could be focal or it could be generalized. A seizure might be unclassified due to inadequate information or inability to place the seizure in other categories. If an event is not clearly a seizure, then it should not be called an unclassified seizure. Rather, this classification is reserved for unusual events likely to be seizures, but not otherwise characterized. So, aware versus impaired awareness. During a focal aware seizure, consciousness will be intact. While, and actually as a practical matter, a focal aware seizure implies that the ability of the person have the seizure to later verify retained awareness. So the patient is aware during the whole event and he knows the events during the seizure. Awareness specifically refers to awareness during a seizure, as we mentioned, and not to awareness of whether a seizure has occurred. So some people, he may have a change in his sensorium, then he realized with experience that, oh, I had a seizure. But when we say awareness, that means he was aware of the event and aware of the details of what was going on. Awareness may be impaired without being fully absent. So the patient probably may have a fog. If awareness of the event is impaired for any portion of the seizure, then the seizure is classified as a focal seizure with impaired awareness. Here, this slide shows discontinued and added terms. As you see, they discontinued using simple partial, complex partial, secondary generalized, convulsion, dyscognitive. Then they added focal aware, focal impaired awareness, focal to bilateral tonic-clonic, hyperkinetic, cognitive, emotional. New focal seizure types and the new generalized seizure types were added. Now, common descriptors of behaviors during and after a seizure. This slide was arranged in alphabetical order. As you see, there are different descriptors under cognitive portion. There are emotional or affective, where the person may have agitation, anger, and anxiety, fear, laughing. Autonomic as asystole, bradycardia, erection, flushing, gastrointestinal symptoms. As you see, this slide is full of these descriptors. Other descriptors also, some automatisms. So when we use those descriptors, usually you see it more in like epilepsy monitoring unit reports, especially if we evaluate for epilepsy surgery, in order to try to make more precise localization of the epileptogenic focus. So this is a summary of rules for classifying seizures. The onset, decide whether the seizure onset is focal or generalized, using an 80% confidence level. Otherwise, the onset is unknown. Awareness, impaired awareness at any point. A focal seizure is a focal impaired awareness seizure if awareness is impaired at any point during the seizure. So it doesn't need to be from the beginning of the seizure. Onset predominates. Classify a focal seizure by its first prominent sign or symptom. Do not count transient behavior arrest. Behavior arrest. A focal behavior arrest seizure shows arrest of behavior as the prominent feature of the entire seizure. Motor, non-motor. A focal aware or impaired awareness seizure may be further subclassified by motor or non-motor characteristics, as we showed in the first slide. Alternatively, a focal seizure can be characterized by motor or non-motor characteristics without specifying level of awareness. Example is a focal tonic seizure. And sometimes in frontal lobe seizures, you see the patient probably may have a focal tonic seizure involving one extremity, but he keeps awareness. Actually, this is a very busy slide, and for the sake of time, I will try to go more quick. This is also, just to show here, the old terms for seizures, the new terms for seizures. Now, with the new classifications also, there were abbreviations made for most important seizure types. As you see, focal aware seizures, abbreviated as FAS. And probably it may appear very busy, but I think with training ourselves how to use those terms, we'll get used to it and they will become simple for us. And I think, in the epilepsy monitoring units, people, they may use these abbreviations a lot. Now, we talked about seizures. Now, what about the classification of epilepsies? As you know, not everybody having a seizure, does that mean he's epileptic? Unless if we go with the definition that we talked at the beginning, about the number of seizures or a seizure with increased risk of recurrence. So the International Classification of Epilepsies and Epileptic Syndromes in 1989, as you see, it was classifying epilepsies into localization-related, partial focal or local epilepsies and syndromes. And they were classified as idiopathic, symptomatic, and cryptogenic. Till 1985, they were classified as idiopathic and symptomatic. Then in 1989, when the term of cryptogenic was added, when we think it's probably symptomatic. Generalized epilepsy and syndromes also were divided into idiopathic, cryptogenic, or symptomatic, and symptomatic, probably symptomatic. And the third class was epilepsies and syndromes undetermined as to whether they are focal or generalized, and there are special syndromes. I will skip this slide. So now, this paper actually, you can use as a reference. Also, again, was made by the task force. And it will, here, the key points about this classification, the revised framework for the classification of the epilepsies designed to work with the classification of seizure types, levels of diagnosis. So we start with the seizure type, as I will show in the coming slides. We start with the seizure type, then we move, next level is to epilepsy type, whether focal, generalized, combined generalized, and focal. These are new terminologies. Unknown, and epilepsy syndrome is the third level. An etiologic diagnosis should be considered from when the patient first presents, and at each step along the diagnostic pathway, a patient's epilepsy a patient's epilepsy may be classified into more than one etiological category, and I will show that in the next coming slide. The term benign is replaced by the terms self-limited and pharmacoresponsive to be used where appropriate. As you see, benign, for example, in benign epilepsy with centrotemporal spikes, the name benign, it may mean to the patient or a clinician that this is a completely benign condition and may not need to be treated, while in fact, as we know, sometimes it may evolve into generalized seizures and it may have, deleterious consequences. So the term benign was changed actually, and they called it self-limited because by age it may, disappear. The term developmental and epileptic encephalopathy can be applied in whole or in part where appropriate. This slide, as you see at the type, it starts with the seizure types, classifying them into focal, generalized, and unknown, as we described the seizure classification at the beginning. Then we move to next level to come up with a diagnosis. And this can be supported by diagnostic tools, EEG, imaging studies. As you see, then it divides epilepsy. The initial classifications were focal, generalized. Now, as you see, there are new types where it says combined, generalized, and focal, where some patients may have both. And some epilepsies are unknown if they are focal or generalized, or they may have different manifestations. Next level is when we have an epilepsy syndrome. And as you see, if you look at the right of the slide, the etiologies, there are 6 etiologies. They classified the etiologies into 6 types. And the patient probably may have more than one. An example, for example, in patients with tuberous sclerosis, where they may have a genetic component, genetic etiology, in addition to structural lesion. As you see here, we add, they added the immune etiology. We are becoming more aware of immune etiology for multiple types of epilepsies. The last thing is the epilepsy syndromes. And actually on the left of the slide, you see comorbidities also. From the beginning of the first visit with the patient, we classify seizures. We may come up with, we may see the patient, they may have some other comorbidities, whether developmental or cognitive issues. So the seizure type, as we said, the starting point of the epilepsy classification framework is the seizure type. It assumes that the clinician has already made a definitive diagnosis of an epileptic seizure. So if you are not sure if it's then we need to be careful whether it was a pseudo seizure or a seizure. So we need to make sure that it was epileptic seizure. In some settings, a classification according to seizure type may be the maximum level possible for diagnosis, as there may be no access to EEG, video, and imaging studies. In other cases, there may simply be too little information available to be able to make a higher level diagnosis, such as when a patient has only had a single seizure. So if I go back to this slide, some areas or some clinicians, if they don't have access, as you see, it's gonna end up just at the first level, whether classifying seizure types, focal, generalized, unknown, or especially if the seizure frequency was not that frequent at the beginning. Then they move for a next level if you have diagnostic studies, and it will be optimum when you leave to epilepsy syndrome. So epilepsy time for diagnosis generalized epilepsy. The patient would typically show generalized spike wave activity on the EEG. Individuals with generalized epilepsies may have a range of seizure types. Hopefully I still have time. Yes. May have a range of seizure types, including absence, myoclonic, atonic, tonic, and tonic-clonic seizures. The diagnosis of generalized epilepsy is made on a clinical grounds supported by the finding of typical interictal EEG discharges. However, caution needs to be exercised for a patient with generalized tonic-clonic seizures and a normal EEG. In this case, supportive evidence would need to be present to make a diagnosis of generalized epilepsy, such as myoclonic jerks or a relevant family history. Sometimes in the clinic, especially and I'm sure it's everywhere, probably in developing countries, when you try to get details from the patient or from the family about the seizure symptoms or the sequence of events during a seizure, all of what they know that the patient collapsed and had a seizure. So we need to be very careful. Sometimes with more detailed questions, you may get a clue if the patients truly have generalized epilepsy, like people who start having their seizures with myoclonic jerks, bilateral myoclonic. So probably it will support our diagnosis that this patient probably has, for example, JME, which is one kind of generalized epilepsies. Focal epilepsies include unifocal and multifocal disorders, as well as seizure involving one hemisphere. A range of seizure types can be seen, including focal aware seizures, focal impaired awareness seizures, focal motor seizures, focal non-motor seizures, and focal to bilateral tonic-clonic seizures. The interictal EEG typically shows focal epileptiform discharges, but the diagnosis is made on a clinical grounds supported by EEG findings. Epilepsy type. So the new group of combined generalized and focal epilepsies exists as there are patients who have both generalized and focal seizures. The diagnosis is made on a clinical grounds supported by EEG findings again. Ictal recordings are helpful but not essential. The interictal EEG may show both generalized spike wave and focal epileptiform discharges, but epileptiform activity is not required for the diagnosis. However, here, I would like to mention that sometimes when you read an EEG, we may see some focal epileptiform discharges, but the history is indicating, or the seizure description is indicating it's generalized. So here we need to be aware of an old term, we used it since long time ago, that these could be fragments of a generalized epileptiform discharges. However, when we see them, then we need to become more vigilant that probably patients may have both generalized and focal combined. Common examples in which both types of seizures occur as Dravet syndrome and Lennox-Gastaut. The term unknown is used to denote where the patient has epilepsy, but the clinician is unable to determine if the epilepsy type is focal or generalized because there is insufficient information available. There may be no access to EEG, or the EEG studies may have been uninformative, for example, normal, or sometimes it may show just generalized slowing, so it does not help us. If the seizure types are unknown, then the epilepsy type may be unknown for similar reasons, although the two may not always be concordant. For example, the patient may have had several symmetrical tonic-clonic seizures without focal features and normal EEG recordings. Thus, the onset of the seizure is unknown and the person has an unknown epilepsy type. As we said, the highest level on the slide with the new classifications is the epilepsy syndrome. And epilepsy syndrome refers to a cluster of features incorporating seizure types, EEG findings, and imaging features that tend to occur together. It often has age-dependent features, such as age at onset and remission, seizure triggers, diurnal variation, and sometimes prognosis. One of the examples, as we mentioned before, could be JME, where you see people, they may have, at certain age, in the teenage, they wake up with myoclonic jerks, or after they wake up, and they may have different seizure types, triggers. There are some people, they may give you certain triggers for their seizures. And then you have the EEG findings with a normal MRI, and you come up with a diagnosis of juvenile myoclonic epilepsy. It may also have distinctive comorbidities, such as intellectual and psychiatric dysfunction, together with the specific findings on EEG and imaging studies. It may have associated etiologic, prognostic, and treatment implications. it's important to note that an epilepsy syndrome does not have a one-to-one correlation with an etiologic diagnosis and serves a different purpose, such as guiding management. There are many well-recognized syndromes, such as childhood absence epilepsy, West syndrome. They have special EEG findings and the description of the seizure types starting in early infancy. Dravet syndrome. Also, it should be noted that there has never been a formal classification of syndromes by the International League Against Epilepsy. Criteria for syndromes: epileptic seizure types, including types must occur to diagnose a syndrome, types that may occur but are not necessary for a diagnosis, and there are types that would preclude a diagnosis of this syndrome. Interictal EEG findings that must be observed in order to diagnose the syndrome may be observed in some cases or preclude the diagnosis of the syndrome if observed. The age of onset, distinctive range for age of onset, how strictly it should be applied for diagnostic purposes. Progressive nature, like epileptic encephalopathy, associated interictal signs and symptoms, particularly neurological and neuropsychological status and deficits. It's important to distinguish between deficits that are due to the cause of the epilepsy, those that are due to pharmacotherapy, and those that are due to epilepsy itself can be difficult. Pathophysiologic mechanisms, anatomical substrates, and etiological categories, and genetic basis. There's no time to go through details of these. Idiopathic generalized epilepsies, well-recognized and common subgroup. 4 well-established epilepsy syndromes: childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, generalized tonic-clonic seizures alone. They used to call them generalized tonic-clonic seizures on awakening, but modified in recognition that seizures can occur at any time of the day. And we see that in our practice. Now, self-limited focal epilepsies. All of these are new terminologies, and with the new classifications, probably it may give us a better communication with patients and even among the clinicians. The most common is self-limited epilepsy with centrotemporal spikes, which we used to call benign epilepsy with centrotemporal spikes, or BECTS. Others include in this broad group are the self-limited occipital epilepsies of childhood, with the early onset form described by Paniotopoulos and the late onset form described by Gastou. Other self-limited frontal lobe, temporal, and parietal lobe epilepsies have been described with some beginning in adolescence and even adult life, especially in those people who do not have a structural pathology on their brain images. Etiology. The clinician should be aiming to determine the etiology of epilepsy from the moment the patient presents with a first epileptic seizure. As you remembered when we showed the slide, on the right side of the slide, so the etiology at all levels, from the beginning, description of the focal description of a seizure, going to epilepsy syndrome. So we need to keep looking at the etiology. Often the first investigation carried out involves neuroimaging, ideally MRI where available. This enables the clinician to decide if there is a structural etiology for the patient's epilepsy. The 5 additional etiologic groups are genetic, infectious, metabolic, and immune, as well as unknown group. A patient epilepsy may be classified into more than one etiologic category. The etiologies are not hierarchical, and the importance given to the patient's etiological group may depend on the circumstances. For instance, a patient with tuberous sclerosis has both structural and genetic etiology, as I mentioned before. The structural etiology is critical for epilepsy surgery. We know he has or she has genetic and structural pathology, but the epileptic seizures can be treated by surgery here, whereas the genetic etiology is key for genetic counseling and consideration of novel therapies such as mammalian target of rapamycin, mTOR inhibitors. Comorbidities. Many of the epilepsies are associated with comorbidities such as learning, psychological, and behavioral problems. These range in type and severity from subtle learning difficulties to intellectual disability to psychiatric features such as autism, spectrum disorders, and depression, to psychosocial concerns. In the more severe epilepsies, a complex range of comorbidities may be seen, including motor deficits such as cerebral palsy or deterioration in gait, movement disorders, scoliosis, sleep, and gastrointestinal disorders. Actually, for example, Rasmussen encephalitis, the patient may start to have seizures and they see deterioration and they may end up with hemiparesis. Like etiology, it's important that the presence of comorbidities be considered for every patient with epilepsy at each stage of classification, enabling early identification, diagnosis, and appropriate management. Here again, just to stress on some points, the new terminologies, developmental and epileptic encephalopathies can be developmental or epileptic or both. It replaces symptomatic generalized epilepsies. Malignant and catastrophic terms were removed. Self-limited and pharmacoresponsive replace benign. Again, this is a slide to just to remind. So as we see here, coming up with the classification briefly, start with first level seizure types, focal, generalized, or unknown, moving to next level to come with epilepsy type. Then if we can come up with epilepsy syndrome, on the left side of the slide, comorbidities can be mentioned from the beginning with the first counseling. Etiology also need to be looked at from the beginning through the whole process of coming up with whether we reach to epilepsy type diagnosis or epilepsy syndrome. And I hope this, I think questions will come late or now. Okay. Is there any way that original diagnosis type might change after some time due to progression of seizures, epilepsies? Yes, yes. I think we, as I mentioned before, during the first visit, you may come up with a seizure type, but then also again, as I mentioned before, you need to make sure it is a seizure, epileptic seizure, or it could be something else. So if it's a seizure, then you may come with, you can classify whether it's focal, generalized, or could be unclassified. Then you with having tools like EEG, imaging studies, or when you get more clear history, probably through some other witnesses, through subsequent visits, then you may gather more information and you may change actually the diagnosis, whether they are seizures or epilepsy type. Yes. Hopefully that answered. Is that okay? Yes.
I believe so, yeah.
Okay, sir, if the seizure duration is less than 10 seconds or might 8 seconds, and all the features and semiology fulfill seizure, but the duration is less than 10 seconds, we call it a seizure or not? Well, we know the focal seizures, or in the previous classifications, they call it simple partial seizures. They could be very brief, could be just 10 seconds. Actually, like aura, using the old terminology, we call it simple partial seizure. And aura by itself is a simple partial seizure or a focal seizure. So it may not have motor. So there are non-motor manifestations, or could be behavioral. Yes, it may last 10 seconds. It could be. And you can make sure also, you may become more confident through, when you take a detailed history, they may tell you that the initial manifestation or the symptom, it could be a feeling, for example, like gastric aura for 10 seconds, followed by some other, whether behavioral or motor or non-motor manifestations in progression of a seizure, and it may end up with focal bilateral tonic-clonic seizure. Yes, so sometimes people, they may have only the beginning of it. It could be 10 seconds. Okay, if the discharges are frequent, independent, and multifocal, will we call a seizure or not? Because the discharges were frequent. Well, you know, I'm not sure if this is a clear question. Do you mean how frequent they are? Are they are becoming, you know, like a cluster? Are they are becoming in trains? Sometimes we call them in trains. Or you mean they are frequent, let's say, in one epoch? As you know, in one epoch of EEG is 10 seconds. Let us say if I see 2 or 3 epileptiform discharges, and they are, even if they are multifocal, I will not call it a seizure. You know, an ictal discharge, usually, the typical ictal discharge, it may start and it evolve, whether in amplitude or frequency, over a period of time, at least 10 to 15 seconds. Dr. Al-Kilani, were certain classification terms like dysfunctional, discontinued, purely for clinical accuracy, or also to avoid social stigmas or family distress? I think, you know, I'm not sure about this, but I think probably for both, it's valid. Whether, you know, dysfunctional, you know, what do they mean by dysfunctional? So we try to avoid any confusing terms. And, you know, for about social stigma or family distress, you know, we know that epilepsy is a cause of dysfunctional life. You know, epileptic patients, you know, they may become dysfunctional. Do you think epilepsy is hereditary? Well, that's a big topic, you know. No, the answer is no. There are some types, we know that, you know, there are genetic factors, yes, but not all epilepsies are hereditary, because there are, as we see, you know, if you remember, we showed in the slide, the etiology are different, okay? There are different etiologies. Some of them are structural. For example, previous stroke, or any brain insult like hypoxic injury or brain trauma. All of these can lead to seizures. Which type is seizure is most common to neonatal and infants? Well, you know, that's also a big question, because there are different, you know, pediatric epileptology is a field by itself. Probably, you know, a pediatric epileptologist may answer better than me. Ajit Kumar, Dr. Kumar, okay, in absence of controlled medications, which medications and approach to first-time seizure in primary health center? Well, absence of controlled medications, you mean probably medically refractory or drug resistant? Well, before we decide which medication, this is an important, you know, that's the importance of this talk. We need to come up with the diagnosis, which type of epilepsy we are dealing with. And, you know, to distinguish, is it focal, generalized? Is it undetermined? You know, there is a big list of medications. Some of them are broad spectrum, and some of them are approved for focal seizures. Some of them, they may cover both focal and generalized. So we need truly to have a clear diagnosis, because sometimes there are some seizures, they may get worse if we use the wrong medication. As an example, you know, in absence epilepsy, you know, people with childhood or juvenile absence epilepsy, if we use, for example, carbamazepine, we know that they will get worse. So we need to come up with a good diagnosis, a clear diagnosis, or if we are not sure, at least we may use a medicine that can cover both, but will not cause harm regarding seizure recurrence or frequency. Although, for example, valproate, it's a broad spectrum, can treat both. They are generalized or focal. So this is, you know, an art, how to choose the medicine after you get, you know, you need to build up a diagnosis first before you choose the medicine. And, you know, you need to consider other comorbidities. It's a big subject, actually. You cannot discuss it, you know, I cannot discuss it briefly here. Okay. Does intraoperative neuromonitoring increase the risk of seizure in patients? No, we intraoperative, you mean during epilepsy surgery? Actually, we use it usually for brain mapping. And nowadays, it's rarely to be used to trigger seizures intraoperative or to map eloquent brain areas, especially now in the era of having functional MRI and other diagnostic studies before going to the procedure. Is there specific anti-epileptic drugs for each type of seizure? Generally, I would say no, but we know that certain medications work better, and actually each medicine, when it was introduced into the market, it was initially approved, for example, for for focal versus generalized. So there is nothing called specific, unless, for example, in absence seizures, people who have juvenile or child absence epilepsy, probably we use Zarontin, but still we can use other medications. What is the best choice for silent epilepsy? I'm not sure what silent epilepsy actually. Do we still have time? Okay, I have a granddaughter.
We have 6 minutes.
Okay, a granddaughter who was diagnosed as epilepsy at the age of 6 months. Until now, she's having on and off attacks. My question is, there is a possibility that she will improve or the epilepsy will subside as she grows? Well, I have a granddaughter. You did not tell me how old is this patient now. You said granddaughter. So it depends on the diagnosis of which kind of epilepsy. For example, if she was diagnosed with West syndrome, she was diagnosed with epileptic encephalopathy. Epileptic encephalopathies usually are progressive. So actually, I cannot answer the question. She needs to be evaluated to know which type of epilepsy she has. Did they choose the right medicine? Then we can discuss the prognosis and the available treatment options. Please explain status epilepsy classification. Wow, we need a big talk. Sorry, doctor. Okay, we need another talk. Are seizures painful or dangerous? Of course, some seizures, there is pain. Some people, they may feel pain at the beginning of the seizures. Like, for example, for tonic seizures, where they feel the hand is stiff, and some people, they may describe it as pain. Dangerous, it depends on the kind of seizures. Of course, some seizures are dangerous, especially if they become generalized. If the patient's having what we call generalized tonic-clonic seizures, they lose consciousness. If it doesn't stop, if it lasts more than 5 minutes, then it could endanger their life, actually. Other than the risk of injuries from seizures, when people lose consciousness or they lose awareness, whether completely or partially, they don't know what they are doing. They are at risk of having car accidents. They are at risk of falls from heights. Different factors can lead to injury. MRI role in early diagnosis. Yes, it plays a major role. However, there are different, some types of epilepsy syndromes that can be diagnosed by history and EEG, for example. There is no need an MRI. Example for that, absence epilepsy, or JME, juvenile myoclonic epilepsy. Usually such patients, they don't need imaging. Is the childhood seizure will affect the elder age? Carbamazepine is best to use if feeling tensions and anxiety, headache in elder age. Childhood seizures will affect the elder age. Some kinds of epilepsy, as we mentioned before, they are self-limited. So basically, they will improve after a certain age. It depends on the diagnosis, which kind of epilepsy. If it has a lesion for that, if the brain MRI is abnormal, there is a tumor or there is a scar on the brain, probably they may continue having seizures and they may need surgery in the future. Now, carbamazepine, as other medications, carbamazepine, as lamotrigine, as oxcarbazepine, valproic acid, all of these medications that can treat epilepsy as well as treating some mood disorders, especially depression and anxiety. How we can classify vertiginous epilepsy? I will call it focal, but it's vertiginous.
Only one more question,
Yes.
Dr. Kinani, then we move to the next topic.
Okay, if a surgeon
One more
wants
question.
a surgery for his patient, but the EEG findings are not focal. Instead of focal, the findings are multifocal. Did the surgeon do the surgery or not? Well, that's a big subject. It needs, counseling in the epilepsy clinic and to look at the complete history, the EEG findings before I say yes or no. How is PDS is characterized in epileptic? PDS, paroxysm. I'm sorry, probably I don't know the abbreviation, or I may forget what is it.
Okay.
In GTC.
Thank you very much, Dr. Mohammed.
Thank you.
I just want to tell you that we have so far reached more than 1,000 participants. So it's a great
Wow.
number, and we thank the organizer and the sponsor for arranging this meeting.
Wow.
Next talk would be on
interesting. Even my daughter, she's a medical student, or she's going for medicine. She asked me to join. So I guess, this topic is
so that's
getting too much
1001.
Yes. Thank you. Thank you, Dr.
The next talk would be held by Professor Gonzalo Alarcon, who is senior consultant and epileptologist, who's going to be presenting on management of epilepsy in women. Professor Gonzalo, the phone is yours.
Thank you very much. Thank you for your kind invitation, and I'm very happy to be with you. Right, thank you. So this is a very fascinating topic. Thank you very much for inviting me to talk about this. I have no disclosures. This is the summary of my talk. We'll talk about preconception considerations, pregnancy, breastfeeding, and other issues not to do with reproduction. But I think what I would like to emphasize in the talk is that when we first see a patient, a female patient with epilepsy, we need to assess many things. Traditionally, it was just if she was on childbearing age, then the risk of teratogenicity. But over the years, a number of other issues have arisen that we need to discuss: conception, contraception, pregnancy, breastfeeding, and so we'll talk about it in this talk. These are typical questions that women of childbearing age come with often in the first clinic. These patients should be reviewed by specialists, as we will see. We should, of course, do all this general assessment of epilepsy, discuss the risk of SUDEP, with different anticonvulsants, prescribing folic acid, and so on, for the reasons we'll talk about. But another question which very often arises, which is, can I pass the epilepsy to my children? And there was one or two questions on this in the previous talk. So as we heard, not all type of epilepsies are genetic, but some are. So if the patient has idiopathic epilepsy, the old term idiopathic epilepsy, which is now sort of genetic, non-structural, non-metabolic epilepsy, then the risk of passing it to your children is relatively small. It's only about 5% if one patient has the syndrome. If one parent has the syndrome, if both parents have the syndrome, then the risk increases to 20 or 7 or 30%. Another issue is, of course, the symptomatic epilepsy is now called structural metabolic epilepsies. Then the risk depends on the cause of the epilepsy. If they are non-genetic, then of course there's no risk. If it's a head injury, post-traumatic epilepsy, of course there's no risk to the children. But if they follow Mendelian inheritance, some syndromes do. Some syndromes with the structural metabolic epilepsies are genetic. Then there's a risk. And if the inheritance is Mendelian, of course, if it's a dominant syndrome, then the risk is 50%. In other words, the woman will pass the syndrome to 50% of their offspring. And if it's a recessive syndrome, then it's 25%. Another thing we need to emphasize, so these are broad figures. Another thing we emphasize is that most people with epilepsy have normal pregnancy. So the reason that the fact that someone has epilepsy is not in itself a reason not to get pregnant. The majority of women with epilepsy will be seizure-free during pregnancy. We'll go into that later. Of course, we will have to continue on anticonvulsants during pregnancy, despite the risks. And we have to encourage women to stop smoking if they're smoking and they're planning to get pregnant. And of course, recommend or prescribe folic acid to prevent teratogenic effects. Okay. So the other thing we need to take into account is there's a high proportion of unintended pregnancies in general population. It's about 65%. In women, it's even higher. Nearly 80% of pregnancies are unintended. So that means really that we cannot wait for a woman to get pregnant in order to give advice. And we cannot wait for a woman to plan pregnancy in order to provide advice about pregnancy, because many of the pregnancies are unintended. And we should avoid changing anticonvulsants during pregnancy, or even changing much of the dose. So that means we should aim at keeping the patient seizure-free, if possible, before pregnancy. There is an increased maternal mortality in women with epilepsy during pregnancies. This is about 10 times more than the general population. Of course, it's a small number, so 10 times a very small number is also a small number, a small proportion. But the main cause is sudden unexpected death in epilepsy. So that means, again, that we should try to get the patient seizure-free, if we can, as much as possible, before pregnancy. There is also a risk of miscarriage, preterm delivery, cesarean section, preeclampsia, and hypertension during pregnancy in people with epilepsy. So these are the NICE guidance from the UK. And during pregnancy, of course, we should use the lowest effective dose of anticonvulsants. And we should, overall, avoid polytherapy. That's very important, as we will see. What happens to anticonvulsants, the interaction between anticonvulsants and contraception? So that's quite a complicated relation. Of course, there is a risk of oral contraceptives not to be effective. So in the general population is 1%. There's a 1% risk of pregnancy during contraception. In women with epilepsy, that increases to 3 or 6%. So that is about 3 to 6 times higher in women with epilepsy than in the general population. Why is that? So one of the reasons is the use of the old anticonvulsants that were enzyme inducers, and as a result of inducing enzymes in the liver by the anticonvulsants, the elimination of contraceptives is increased and the blood levels are decreased. So that means we might have to go on women with epilepsy on enzyme inducers higher than the recommended dose of 50 micrograms. The effect is lower in implants, but it's still affected, so we have to take into account. And because of these risks, of course, we should administer folic acid in people on contraceptive in case the contraceptive oral contraceptive fails. And which are the main enzyme-induced drugs and in terms of anticonvulsants? So the most common, the most effective, or the classical enzyme inducers are the old anticonvulsants: phenobarbital, phenytoin, carbamazepine, oxcarbazepine, and topiramate at high doses. So these, because they induce enzymes in the liver, they increase the elimination of other drugs like warfarin, statins, anti-poor cholesterol, or contraceptives, and these drugs become less effective. We have among the anticonvulsants an enzyme inhibitor, valproate. This anticonvulsant it reduces the metabolic rate, the elimination rate in the liver, and of course it can then increase the levels of lamotrigine, phenobarbital, and other drugs. So we have to take this into account during pregnancy and during contraceptive. What is the relation to the mutual interaction between anticonvulsants and the contraceptive pill? This is interesting because some anti-epileptic drugs reach levels of oral contraceptives, and these are mainly the classical enzyme inducers plus the lamotrigine. But the oral contraceptives also reduces the levels of anticonvulsants, particularly for oxcarbazepine, lamotrigine, and valproate. And there are other studies that show that there are no interactions between these anticonvulsants and oral contraceptive. As you can see, valproate is in both lists. And these anticonvulsants that do not affect oral contraceptive or the opposite are mainly the new anticonvulsants plus the benzodiazepines, lacosamide, levetiracetam, pregabalin, and so on. Now, if the patient happens to want to get pregnant, then we have to consider other factors. First, the fertility rates is lower in women with epilepsy than in the general population. About more than one third of menstrual cycles are anovulatory. And there are a number of factors for this. There are social factors. There are lower rates of marriage or later marriage in women with epilepsy. Many women with epilepsy self-isolate because they're afraid of having a seizure in public, so they don't go out. They are decreased sexual activity, either because of the syndrome or because of anticonvulsants. There is also a personal choice. Some women do not want to get pregnant because they don't want to pass the epilepsy to their children, since it's such a horrible disease. There are also genetic factors. Some syndromes are genetic and have a high level of infertility. And also the anti-epileptic drugs. Many of them affect the libido, they affect hormonal levels, and of course valproate can produce polycystic ovarian syndrome, which is fortunately reversible in most cases, and produces infertility. So the next thing is, if the patient gets pregnant, what are the risks? So the main risk, the classical description of risks in this population is major congenital malformations, particularly spinal bifida, cardiac malformations, and cleft palate. And this is increased about 2 or 3 times higher than in the general population. And it is a dose-dependent effect. So the higher the dose of anticonvulsants, the more severe and the more likely the malformations will be. And also is very much increased by polytherapy. So before pregnancy, we should try to control the epilepsy with one medication only. And particular culprit for this, as we will see, is valproate. Valproate has a high rate of teratogenicity, and particularly if it's administered together with other drugs in polytherapy. So this is the risk of teratogenic effects in women pregnant on different drugs. The highest risk is, of course, valproate, 9.3%. It's a very high dose. Remember, the control is 1.1 in this study. Then it goes phenobarbital, 5.5%, nearly half of valproate, topiramate. And then we have a number of anticonvulsants with a relatively low risk, but still a risk, clobazam and clonazepam and phenytoin. And then we have other medication with lower risk, Keppra, levetiracetam, oxcarbazepine, lamotrigine, gabapentin. So this is effects on after birth. So the effects of valproate and other medication are not restricted to the teratogenic effects during pregnancy, but they can seem to have been able to produce longer lasting effects if the children are exposed to it in pregnancy. So these are children who do not have epilepsy, but they were born from patients with epilepsy who were pregnant. This study compares lamotrigine, valproate, and carbamazepine, and looks at developmental delays in these children according to the standard scales, and it shows that 40%, nearly 40% of people on valproate, people who had been exposed to valproate in their pregnancy, develop developmental delays. That goes down to nearly half, 20% on carbamazepine, and interesting on lamotrigine, the risk is even lower than control. As the child grows, this is a study who have recruited patients at the age of 6 years who had been exposed to different anticonvulsants during pregnancy. Mainly the valproate shows a lower IQ than the others. So again, this is valproate seems to be the worst. And this is a interesting Danish study which looks at school performance. So this is an overall performance, cognitive performance in children who have been exposed during their pregnancy to the different anticonvulsants, and there is a deficit, an underperformance on children exposed to valproate and clonazepam, not so much to carbamazepine, lamotrigine, phenobarbital, or oxcarbazepine. So this is interesting. So when you expose babies, fetus, to different anticonvulsants, some of them can produce teratogenicity, but also longer lasting cognitive effects and developmental delays later in life. And this is so much so, the effect is so striking that the European Medicines Agency, EMA, has advised, has this rule that women who have to be on valproate, if they are on childbearing age, they have to go through this program where they explain to them all the different side effects and the risk of valproate, and they have to agree to them if they want to take valproate. Of course, they will be offered alternatives if possible. What happens to anticonvulsants during pregnancy? This is another big chapter. So some levels of anticonvulsants are decreased in pregnancy, particularly of oscarbazepine, lamotrigine, and valproate. And this is probably due to a number of causes. There are many changes during pregnancy. There are decreased absorption of medication, increased metabolism, decreased protein binding, increased protein levels, decreased gastrointestinal motility. Also, there is fluid retention, so the medication is diluted. There is increased renal clearance, hepatic clearance, and so on. So this affects many anticonvulsants, but the one that is affected the most is lamotrigine. Lamotrigine is metabolized by the glucuronyl transferase in the liver, and any and the estrogens and progesterone induces this enzyme in the liver and reduces the levels in blood. Sometimes the clearance is reduced by 94%. And often in pregnancy, we need to increase, double, or even sometimes multiply by 3 the pre-pregnancy level dose of lamotrigine to keep the same levels in the blood. Remember that the effective fraction of the drug, of any drug, is the free levels. But what we measure in the standard test is the overall level in the blood of the drug, the amount, the fraction joined to proteins, and the free levels. So in pregnancy, as we have seen, there are different changes in protein levels, and what we need to look, if we need to look in terms of blood level monitoring of these drugs, is the free levels.
Unfortunately, the time is over.
Do I have a few minutes?
Okay, only 1 more minute, please.
Okay.
Then we have many questions.
So what happens to the impact of pregnancy on epilepsy? In some patients, the epilepsy gets worse. In others, it gets better. Overall, it doesn't change. What we need to know is that the best predictor to become seizure-free, to be seizure-free pregnancy, is to be seizure-free before pregnancy. These are the risk of seizures on pregnancy: maternal fetal hypoxia, heart rate deceleration, increased risk of labor and premature and stillbirth. What do we need to do in pregnancy? First, to avoid polytherapy, to try to use the lowest dose, and to check, if we want to check, free levels. And we need to, of course, administer folate, which decreases the risk of teratogenicity. And in patients with enzyme inducers, we should administer vitamin K for the last 4 weeks of pregnancy to reduce hemorrhage in the neonate. Breastfeeding epilepsy. Some of the drugs have high dose in the milk, particularly phenobarbital, ethosuximide, and lamotrigine. So we should avoid them. Breastfeed in patients who have this medication. And if we want to do breastfeeding, then we should time the breastfeeding to just before the next dose. So do the breastfeeding, if possible, when the levels of the drug are lowest. Catamenial epilepsy. Many patients have seizures, particularly around their period, so we can treat them with clobazam, 10 milligrams Nocte, for 2 days before the period and during the period, and that reduces the problems of tolerance and addiction. And we can also give acetazolamide, which has a mild diuretic effect. It is also effective. Weight gain and cosmetic effects. Topiramate and zonisamide produces weight loss. The 3 Ls, lamotrigine, levetiracetam, and lacosamide, plus oxcarbazepine, does not affect weight level. It's weight neutral. And valpapentin, carbamazepine, and pregabalin can increase weight. The other problem with women in epilepsy is, of of course, women at high risk of osteoporosis and fractures, and enzyme inducers can induce enzymes in the liver, but also in the bone, and can increase the risk of osteoporosis. Not only that, but also they increase the metabolism of vitamin D. So these two factors can increase osteoporosis in women of older age. So we should avoid enzyme inducers in these patients. So in summary, we have many factors involved in this situation, women with epilepsy, and we should aim at seizure-free before pregnancy and counsel the patients before when they come to see us first, before they are even intending to get pregnant. Thank you very much. Any questions?
Thank you, Professor. We have 5 minutes to answer a few questions here. One of the questions is here. Thank you for good information and highly appreciated. For nutrition therapists, the ketogenic diet is the most well-established dietary therapy for epilepsy. And Atkins diet and polysaturated fatty acid and restriction of calorie. Probably they want our opinion about it.
Sorry, what is the question?
Ketogenic and Atkins diet.
In women or?
Overall for epilepsy.
Yeah, I mean, it is effective, and but it's very difficult to keep. And mainly pediatricians using with some children, some syndromes. It seems to be more effective in some syndromes than others. For adults, it seems to be very difficult to maintain, and also increases the cholesterol and other things that. So what I would say at the moment is mainly as second choice treatment, and in my experience, mainly pediatricians use it, but it's not the first choice.
Probably if the patient is having a tractable seizure and we're exhausting all the epileptics, we can consider this.
Exactly.
How can we induce paroxysmal non-epileptic seizure in patients with an EMU?
Well, there are different maneuvers. Is a suggestion, yeah. So there are many ways. I mean, in some centers they have injected saline IV. Others do photic stimulation. Others they just suggest to have a seizure through speaking to the patient. So most of them, you ask the patient to have this particular maneuver because it can induce seizures in some patients. So it's a form of psychological suggestion.
Okay. So there's another interesting question. Is seizure curable if you treat it early?
Well, this is an old question. Of course, the problem arises when patient comes the first seizure. So when patient comes the first seizure, or the second has the first seizure or the second seizure, there is a school of thought that believe that the seizures beget seizures. So if you have more seizures, you're more likely to have seizures later. And this is mainly based on the Kindle model in animals. So these are rats, usually rats that you stimulate the hippocampus and produce seizures. You stimulate the hippocampus repeatedly, and initially you don't produce seizures. But if you carry on stimulating, a stimulation that will not produce seizures earlier will end up producing seizures. And the more you stimulate, the more seizures will be produced, and the more seizures the rat will have. This has never been proven in humans, In fact, in humans, overall, if you consider all the epilepsies, the prognosis is quite good. So the fact that you had a few seizures doesn't mean you're going to have more seizures at all. So I don't believe that so much in humans. It is true that the cause of the epilepsy, the cause of the initial cause, will determine what will happen to the patient. So some, as we heard in the previous talk, some syndromes are self-limited. They might have many seizures and then stop having seizures according to the syndrome and according to the age. And others, in other syndromes, the seizures continue and the epilepsy gets worse. But very often the epilepsy with the years gets better. So that will go against the model of kindling in humans.
It's now 9:30, so we conclude the talk. It was a very interesting talk. Thank you, Dr. Mohammed, Professor Gonzalo. Just to inform you that we reached more than 1,000 participants, including Dr. Mohammed's daughter, became 1,001. We're going to promise the participants we're going to have more epilepsy series in future, and it's going to be more interesting. Mohammed, you had some?
Yeah, we would appreciate, if we, like next, during future talks or meetings, it will be nice if we know about who are the audience, if all of them are clinicians, non-clinicians, and what are the specialties, so we can formulate our talks to be, like understandables at different levels.
So it's a mixture of general practitioner to nutritionists to general neurologists as well. Some of them are epileptologists.
Okay.
Too. So it's a mixture of all. So
because
you need different.
I felt my talk probably then was difficult for some people, because I thought it's among neurologists and maybe some other clinicians like internists. But apparently it seems there are parents and family members also, yeah.
Okay. So thank you very much. See you in future. Thanks a lot for both of you to
Thank you.
attend
Thank
this
you very
meeting.
much. Thank you for the organizer.
Have a nice time. Thank you.
Thank you.
Thanks. Bye.
Thank you, doctor.